Let's talk about a couple of things. So I will be talking about infective endocarditis and rheumatic heart disease. I'll start with rheumatic heart disease. So rheumatic heart disease is defined as a sequelae of events following an infection with group A beta hemolytic strep. Yeah. So in the epidemiology map, in Kenya, it is the youth who are affected, young people. So 16 years going up, but less than roughly 30, 40 years there. And obviously, the etiology is you have people who have been infected with strep. And you know, strep causes things like pharyngitis, pneumonia, meningitis, even. So you have to ask in your history, yeah, has the patient had this? It also causes necrotizing fasciitis. So has the patient had any of skin changes, anything in the resp, anything up in the brain? So inquire, yeah. And then for the pathophysiology, there's some, okay, is there a question in the chat? Okay, I'd seen somebody earlier had asked if we are allowed to put something in the PC if it's not what brought her to hospital. Let me tell you one thing. The patient is the one who you know what brought her to hospital. Let me be real with you, you know. So, Joy, the patient does not have medical understanding. The patient came to seek help because they are not feeling okay. To really describe how they are feeling because English isn't our first language, it's hard for a Kenyan. So you'll find what you will focus on might be that the difficulty in breathing or the shortness of breath is also additive to that. Yeah, I hope you understand what I mean. Like it is for you to interpret. Like don't let Hutchison says the patient should, but you know, Hutchison is tailored by the white man. The white man English is their first language. In Kenya, we have your native language being your first language. And sometimes when they describe a condition, they try to translate, yeah, in their heads and bring it out, and it leaves some things out. And when you're talking to them, you'll see those things come up. And so you add, seeing it make sense. I hope that makes sense to you, Joy. So Sasa. So the pathophysiology involves molecular mimicry. I will not get into this. You guys should be familiar with the pathophysiology of rheumatic heart disease. Yeah, but just know that the cell wall of the strep resembles the M protein of cardiac myocytes. Yeah, and you need to remember that it's 2 to 3 weeks after infection with a gas with a group A beta hemolytic strep. Yeah. So the diagnostic criteria is something you'll hear about oftenly while you are in the wards. You'll hear about the diagnostic criteria for rheumatic heart disease, and we use Major Jones or Jones criteria. Yeah. So Jones is a mnemonic in itself. So you put Jones like I have, and Jones, J for joints or migratory polyarthritis, and then O for pancarditis, and then N for subcutaneous nodules, E for erythema marginatum, S for St. Vincent's Dance or Sydenham chorea. That's what it's called. Then minor Jones is polyarthralgia, high fever, elevated acute phase proteins like CRP and ESR. And then the ECG will show prolonged PR intervals. So for diagnosis, the rule is normally two major. It's two major or one major, two minor. Yeah, just give me a moment. So yeah, the rule is two major or one major, two minor. You guys should remember that when you're up there and you're defending your history, the first question will be from your history, does your patient meet the criteria? Yeah. Does the patient meet the criteria for diagnosis with this? Yeah. So this word criteria, just know a couple of the key criteria that you should know in medicine. Yeah. So Jones, Dukes, those ones you should know. You should know that one for SLE that I've forgotten, but I think we might have a session on that soon, and by then I will know. So those criteria are very important for you to know. And so you just know them, and in your history, can you say you've had this? You've had this. Like you see in the history that Chandra just presented, you could see that a couple of systems weren't explored. to tell me if the criteria has been met, because she's possible for reinfection. So you need to know, uh, could she be having a reinfected, something happening that has happened before, yeah? So, okay, let's talk about the clinical presentation. Before we get to the clinical presentation, how many of you know how to do the CVS exam? Let me pick someone. Barbara, are you familiar with the cardiovascular examination?
Not very confident with it.
No problem. We're here to discuss based on what you know. So build me up until the point where you feel you're sure, kabisa.
Sorry?
Like just take me up until the point where you feel you're least sure. So start from where you're very sure how to start it to the point you're least sure.
I know the person is supposed to be seated at a 45-degree angle to
Mm-hmm.
begin with.
Mm-hmm.
You start with the examination of inspection of the hands. You look
Mm-hmm.
for cyanosis, finger clubbing, signs of infective endocarditis, the what's it called? I've forgotten the name, that one. And warmth of the extremities. Then you do like the inverted J, basically.
Mm-hmm.
That's what I remember.
That's okay, Barbara. So as Barbara said, but there are a couple of important things. And once again, in fourth year, they don't want you to know the big things. They don't want you to be good. You'll meet guys in the ward and they'll be like, oh, I know this mama, I know this mama, I know this mama. They don't want that. They're very simple people. And this is where people fail mostly. And they say, oh, that examination was hard, that lecturer was mean, he was just focusing on things that sound so basic, but me, I know these advanced things. But they don't care about those advanced things. Yeah. So you start with introduction. So you do wipe. Wipe is a mnemonic. W for wash your hands. And for I think I did it with group B on Saturday. So washing your hands, what does it involve? There is a step process to sanitizing, even using the sanitizer. You don't just splash it on your hand, rub it, and that's it. You follow the steps. I think you guys will look for time and tell me when in the week works for you. And I'll see if it's possible within my schedule. And then, so you wash your hands, you sanitize, then you sanitize your stethoscope. Yeah. You introduce yourself to the patient. So say, my name is Sean Omondi. I'm this student and I'm currently doing an examination that will involve me looking at your hands, checking for your pulses, checking your blood pressure, feeling at your neck for any swellings, looking at your eyes, looking at your mouth, looking at your chest, feeling and listening to your chest. Is that okay with you? Yeah. That's gaining the patient's consent, and it's called informed consent. It's not asking the patient, mama, unaweza toa shati nikusikize kifua? No, it's not that. Informed consent is walking the patient without using the medical jargon, with using simplistic language, explaining to the patient what you want to do. Yeah? Simplifying it, what you want to do, and you ask the patient to agree, and they agree, and then you proceed to examine. That's wipe. And then after wipe, what do? You start, number one, position the patient appropriately. As Barbara has said, the patient should be reclined. The word is reclined, not seated, reclined at a 45-degree angle. Yeah. And then after that, you would want to expose the patient from the waist upwards. Exposure is key. Those are the things that they mark. They don't care about you knowing those complex things. If you don't expose that patient correctly, you're fighting for a 50. And that battle is you're losing. So you have to expose the patient properly. Up until that point, you might be at a 50. Just explaining, doing wipe, and exposing the patient well, you're at a 50. Then after that, what you do is now you start the examination. And as Barbara said, you do the general exam, CVS focus. Yeah. So you start looking at the hands, and it's a comparative exam. You have the patient show you both of their palms, and then you compare them with your own. You're looking for pallor, yeah. You're looking for osler nodes. You're looking for Janeway lesions, yeah. Then you are looking for also palmar jaundice, yeah. Then you have the patient turn, yeah. While they turn, you shine at diagnostic lamp. These are the things I wanted to do with you guys physically, because doing them online doesn't do them justice, yeah. So you will shine a lamp under the nail, under the pulp of the fingers, to fully see the nail bed. And that's how you say splinter hemorrhages, whether they are present or absent, yeah. And then after that, you will also look for, you guys know something called quickness signs or something. The pulsations of the nail bed. I hope you guys are familiar with that sign. But if not, okay, guys, please go and read on that. So after doing that, you will also say splinter hemorrhages present or absent. You will look for the clubbing. You look at the cyanosis, yeah. And then after that, you proceed to the pulse. There is a technique for checking the pulse, and we'll do it when we are physical. But reporting the pulse is important as well. So when you're reporting the pulse, there are only like three ways you report the pulse. It is either regularly, regular, not the adverb of manner, regularly, regular. Then regularly, irregular. And then irregularly, irregular. The adverb of manner, then what you're saying. Adverb of manner, then what you're saying. Adverb of manner, then what you're saying. Yeah? Then after that, you proceed to take the blood pressure. Be familiar with how to use the sphygmomanometer. Very important thing to know, because that's the BP machine. They don't use the auto BP machine in the CVS ward. You could literally be going for an end of year exam, and the lecturer just says, I want to see how you take a blood pressure. Describe how you take a blood pressure, and your exam is over. So now you go there, you don't know how to use the manual. You say you put the cuff and you turn on the machine. You're fighting for your life there, yeah? So you have the cuff 2 centimeters above the enterocubital fossa, and then you will make sure the cuff is fully deflated of the right size, of course. And then you put the cuff around the patient's arm, just 2 centimeters or 2 finger breadths above the enterocubital fossa, yeah? And then after that, you make sure the tubing is not twisted in any way, and you make sure the valve is closed. You palpate for the brachial artery. When you do that, how you will do that is you normally accentuate for the biceps tendon. It's normally just medial. Sometimes you'll find it medial, depending on how the patient's anatomy. You'll find it medial to the biceps tendon, if I can remember. Medial or lateral, depends on how you feel it. So you'll palpate, you'll just feel, depending on how it's overlying. So you'll feel it, you look for it, look for the brachial artery, you'll palpate, then you inflate your cuff until you can no longer feel that brachial artery. Then you inflate 20 to 30 millimeters of mercury higher. And then after that, what you do is now you place the diaphragm of your stethoscope over the brachial artery, release slowly, roughly 2 to 3 millimeters of mercury per second, while listening for the correct of sounds. So first correct of sound is absolute systolic blood pressure. Then you open up until correct of sounds disappear or they become muffled, and that is absolute diastolic pressure. Then after that, you go to your neck, you look for distended neck veins, any pulsations. I'll describe how to look at the JVP. I'll describe how to feel the carotid, because saying them right now makes no sense. And then you look at the eyes for sure. You're looking for any scleral jaundice, conjunctival pallor. You look at the mouth. You look for any cyanosis. You look for any mucosal jaundice. Yeah. And then now you come to the chest or the precordia. Patient is at 45, well exposed. You go to the foot of the bed. Squat to eye level. Squat, go down. Look at the precordium. Is it hyperactive, normal active? Yeah. Are there any scars? Is there any chest wall deformity? You see, Then after that, you come to the right side, confirm there are no scars, confirm if there's any pulsations. Are those pulsations venous or arterial? Once again, when you meet physically, we'll discuss all that. Yeah. And then once you do that, you palpate for the apex beat. And you normally do it clinically, knowing that you don't start going and looking for it anatomically, doing fifth intercostal space, because you're in the CVS ward. It'll be displaced, a couple of them. You look for it. Then you go to the angle of Luyo, the sternal angle. That's the second intercostal space. Move down, counting the ribs. Find where it is. Is it mid-axillary, anterior axillary? Those are things you have to know, yeah? Then after that, there's obviously no percussing. You auscultate. For auscultation, if I talk about auscultation now, you guys will not like me because it has to be done physically. So you guys schedule a time and we talk about it visually. So yeah, so after doing this, maybe I could ask somebody, could somebody be willing to take us through what they expect to find clinically in a patient with rheumatic heart disease, given that I've described the exam? Given that I've described the exam.
Could you find like nodules on the hands, like subcutaneous nodules?
Mm-hmm.
When doing the inverted J, like just looking inspection.
Yes, thank you, Brenda. That's very good. So in inspection, you can find any of the nodules. You could find the subcutaneous nodules. Mm-hmm. What else could you find on inspection? On general inspection?
Can you, if the patient is a bit light-skinned, can you maybe see malaflush?
Why?
Because rheumatic heart disease usually presents with mitral stenosis, which presents with a malaflush on the cheeks.
I would like to kind of shake that belief a bit. Number one, as I've said, in Kenya and in third world countries, rheumatic heart disease is common among the youth. Yeah. So that means the most common presentation of rheumatic heart disease among the youth is normally mitral regurgitation, not stenosis. So I hope
All
that.
right.
Okay, let's continue, guys. On general inspection, what did you guys see? Maybe I could call somebody. AJ. Okay, maybe AJ is not with us.
Sorry, can you
Yes,
hear me?
yes, I can hear you now.
Maybe just like upon looking at the patient, you could just look at like the involuntary movements caused by the synonyms chorea.
Okay, that's a bit reaching, but it might. In Kenya, we don't see that. But okay, so you could see that.
Can you see these erythema, the
Yes,
marginatum erythema?
yes.
Those they spare the face, but they're usually in the trunks and the trunk and the hands, I think.
Right. That's good. That's very good. What else now? Let's move from general inspection to CVS inspection. You've looked at the hands. Now, what do you expect to see at the hands?
Splinter hemorrhages.
Why?
And then,
Why would you see splinter hemorrhages, Yasmin?
it's a sign. Or, no,
Rheumatic
that's
heart
it.
disease?
Okay.
But okay, thank you so much. I know Keith is in the meeting. Maybe we could do it with Keith. Maybe I don't know if I could. Keith, are you in the meeting?
Yeah, I'm in the meeting.
Okay, Keith. Let's
Mhm.
let's run through how what we would expect to see in a patient with rheumatic heart disease. So, an inspection of the hands.
No, also you'd maybe find there are swellings in the joint.
Mm-hmm.
Uh, you'd also find what else? Uh, what else did you find?
That's actually what I needed to hear, the swelling at the joints.
Okay, yeah.
Swelling at the joints. Then after that, obviously pallor, because this patient is in heart failure. Cardiac output is reduced. Then you go to the pulse. How would the pulse be, Keith? Normal volume or low volume?
Since the patient has reduced, then you'll find high volume pulse.
Thank you. Then what else would you guys see? Because it will be high, it could be normal, it could be low. So don't be shocked, guys. When you feel that pulse, just describe what you feel. Don't doubt yourself. So don't doubt yourself, guys. You guys are on. You guys know these things. So you feel the pulse, then you go, you take the blood pressure. The pressure most of the time is normally low. And then you'll go and you look at the eyes. We could find conjunctival pallor, very rare to find jaundice. Then now you go to the mouth, the dorsum of the tongue, you will find there are signs of pallor. And then after that, you look at the neck, the JVP won't be elevated. There won't be distended neck veins on the neck. There won't be any visible pulsations on the neck. Then to feel for the carotid, we'll talk about that one. You have to talk about physically. Yeah? Then on inspection of the precordium, this is regurgitation. This is not stenosis, yeah? So will the apex be heaving? We will talk about these things, guys. I hope you guys show up to the physical session so that we can be able to discuss. Give me a day and I'll ask you guys to vote on a poll. You give me a day that works for you and I plan myself accordingly because these ones we can't discuss like this. We have to do them. Sasa. Thank you so much, Keith. So the classical presentation is mitral regurgitation, as we said. So patient will tell you the usual. They're tired, feel bad when they work out, exertional dyspnea. They try to walk, they feel tired. Weight loss, obviously, because in heart failure, there's cachexia that occurs because now you're not pumping the same kind of blood. The muscles are not getting nutrients, they're dying. Then there are the usual palpitations and the chest pain, cough, difficulty in breathing, and then it's normally asymptomatic in patients with mild mitral regurgitation. And we said that mitral regurgitation as a presentation for rheumatic heart disease is common in younger patients. And as we've said, that our population that is exposed to RHD is normally the young group, yeah? So for the signs, you will see normal to low volume pulses. They could even be high. You could find that the JVP is not elevated. The first heart sound is normally normal, but you get a pansystolic murmur radiating to the axilla. We'll talk about this pansystolic, mid-systolic, early systolic, late systolic, early diastolic, mid diastolic. We'll talk about them. So don't worry about it. And this is the mitral valve anatomy. It's important to know these things, yeah? Sometimes you are chilling and you think you've gotten away with it, and then they decide to pimp you with this stuff, yeah? So this is how the mitral valve looks like. And I hope you guys understand the physiology of a valve, yeah? Maybe I could just ask somebody to talk to me how they think a valve works. I don't want complex things. Yasmin, are you in a position to talk or to answer us? How you think a valve works?
I can try.
Okay.
So basically valves are like one-way gates.
Mhm.
Ideally, they should allow blood to only flow one way and not the other way. So for example, for example, for the mitral valve, it has two leaflets. So ideally, when the two leaflets open, blood should flow from the left atrium to the left ventricle, but it should not be allowed to flow backwards because when they close, they kind of latch together, so it prevents blood from flowing backwards when the left ventricle is filled. But yeah, if there are any abnormalities or whatso, you can have regurgitation.
Thank you so much. Thank you so much for answering that. You did physics?
Yeah,
You did physics, A levels, I think.
yeah.
So I want you to think of the heart as a pressure chamber, yeah? Because that's what the heart is. To understand the heart, you have to really be familiar with the physics. The heart is a pressure chamber. What you said is true. Valves are one-way gates. And they do that because once the blood is pushed out, what happens is you get a region of negative pressure. And nature abhors vacuum. Yeah? That's why a little blood, the end systolic volume, is normally left to make sure the heart doesn't collapse in on itself. Yeah? To exert that negative pressure. So there's negative pressure that's left. Yeah. This negative pressure literally either forces one of two things to happen. Either the blood that has been pumped out should come back, or it forces the valves to close so that blood doesn't come back. Yeah. So in a patient with regurgitation, what you're having is that every time the heart is attempting to pump blood, this region of negative pressure left behind in that particular chamber, in this case, the left ventricle, yeah? This particular negative pressure that is left sucks the blood back in, yeah? Because think of negative pressure as how you get soda into your mouth using a straw, yeah? That's negative pressure. You suck all the air out, the fluid follows, other fluid follows, because air is a fluid. But that's the basic game, yeah? And to really understand, why does this murmur radiate to the axilla? Because if you remember the position of the heart in situ, yeah, or in situ, the position of the heart is you have something that is almost angled towards your axilla. So as the blood is moving back and it's refilling the chamber, trying to be pumped out, coming and refilling the chamber. And that's why you're hearing this abnormal sound radiating to the axilla, and you're hearing it throughout systole anytime the heart contracts for that period during that phase. I hope that makes sense. I hope that makes sense. That has helped you guys and to understand this concept of regurgitation. If you make cardiology, I told you guys the approach to cardiology is quite simple. If you make it complex, it becomes complex. So make it very simple and just use the physics, the science that you remember about pressure, about systems, to be able to make it easier. So that is the anatomy, just as we've heard. So we're going to talk about infective endocarditis here. I'm not going to talk about a lot. So infective endocarditis, the diagnostic criteria is modified Duke's criteria. And the mnemonic is this: B, timer. The first B and E are major criteria, and the timer is minor criteria. Yeah? So B, blood culture positive. E, echocardiographic evidence of endocardial involvement. T, temperature greater than 38 degrees Celsius. I, immunological phenomena like Osler nodes, rod stoats, genital lesions. Then M, microbiological evidence or culture. E, embolic phenomena. R, risk factors such as congenital heart conditions or IV drug use. That is modified Duke's criteria. So in your history, be on the lookout for these criteria. They actually make doing your history very easy and going through, so that you can go through the criteria and be like, okay, does my history meet the diagnostic criteria for me to be yapping infective endocarditis? Or what is lacking? What questions didn't I ask? Or did I ask them and they're telling me this? Yeah, so that's important. So this is just the criteria. You always keep in mind the criteria. And then now, the risk factors are simple. You have to have a structural heart disease. So people with rheumatic heart disease are at risk of getting infective endocarditis. Yeah? You find people with prosthesis, very common. People with DCM, dilated cardiomyopathy, can get it. People who have turbulent flow and endothelial denudation, yeah? Have people with pressure issues, yeah? People with sterile vegetation. It initially is sterile, becomes bacterial, and it happens to a subset of the population. Then there are people who've had prosthetic valves. There are people who had instrumentation, maybe from the dentist. Yeah. So those are things you need to know. And then you find people who are IV drug users. That's the most common, but it's rare in Nairobi. Because in Mombasa, it's very common. But here in Nairobi, it's rare to find IV drug users. So once again, poor dentition is important, yeah, because you guys should know Staph aureus. You need to know the viridans group. Then there's hemodialysis, very important. You find a patient who has been on dialysis in the cardiovascular ward, important to query infective endocarditis. Things like diabetic mellitus, obviously because your immune system is down. Chronic liver disease, once again, your immune system is down, bacteria is running wild. You have anything that causes a reduction in immunity, of course, neoplastic disease, any malignancy, and an indwelling intravascular devices. That's why hemodialysis is important. People with chemopods, so this is a very common things that you could know. So I've just taken you guys through the cardiovascular examination. I don't know. What do you guys want from, when are you guys available? We do this. I'll send a poll in the group to make it easier so that we can discuss this. So far, any questions? Any questions so far? So if you don't have a question for me, maybe I'll pose a question for you. Mercy Etemesi, are you with us?
Pardon?
Are you with us?
Yes,
Are you in a position you can talk?
not a lot.
Okay, sawa. I'm looking for somebody I want somebody to extensively describe what they know about the cardiovascular examination now. Ian, are you with us, Ian?
Yes.
Talk to me about the CVS exam, what you know, whatever you know.
Oh, okay. So from what you said earlier, we start with washing our hands, and then we inspect, and then also ask for permission from the patient, and then now we could examine. So after that, you said we check the hands, so both of the hands, and we try to compare with ours. So on the hands, we are checking for parla, we are checking for genuine lesions, which are usually found on the palms of the hand, and they're usually non-tender, and osseous node, which are usually on the palms of the fingers, and they're usually tender, splinter hemorrhages on the nail beds, and for here you said you check using a light source. Yeah, and then from there you check the radial pulse, and for radial pulse, we are checking for the rate, rhythm, and character of the pulse. And then you mentioned that for the rate, you can only document it in 3 ways. So regularly, irregular, irregularly regular, or irregularly irregular. Yeah, and then we could now move to assess the blood pressure, which you mentioned you're supposed to know how to take the blood pressure using the sphygmomanometer. And then you'd now move towards the face and the neck. So in the face, you'd assess for conjunctival pallor, you'd assess for scleral jaundice. You now move to the mouth, where you'd assess for mucosal jaundice and central cyanosis. Then in the neck, you'd check for the jugular vein distension, so the pulsations, which you differentiate between either being arterial or venous, and then you'd also assess for the carotid pulse. And then on the chest, you'd start with inspection. So inspection, you're checking for any visible scars, abnormal masses, chest deformities like pectus excavatum and carinatum, and yeah. And then after inspection, so inspection, you said we do it at the foot of the bed while you're squatting. So, and then after inspection, you'd there's no percussion, so you'd do palpation. So for palpation, you'd assess for the apex beat. So that when you do it from the angle of Louis, so the angle of Louis usually corresponds to the second rib. So, and then now you'd move until where you'd reach the apex beat, so to try and check if it's displaced either laterally or medially. That would be indicative of a pathology. And then I think that's why we stopped. We didn't go in depth to the auscultation.
That's okay. Thank you so much, Ian. So now, Ian, I would like to leave you on for a bit. Why do you think I insist on shaking the patient's hand?
To create a rapport with the patient.
Important, but why? What else? What other thing is important in shaking the patient's hand? Ian, have you heard of the term cold and clammy peripheries?
Yeah.
Which condition do you see cold and clammy peripheries in?
So cold and clammy peripheries, you'd see it in coarctation.
Another one?
You'd also see it in heart failure.
Thank you. Shake the patient's hand, and shaking it has diagnostic purpose. So when you're there with the patient, shake the patient's hand firmly, feel it, and report to the examiner. Patient has no. Don't tell the examiner, don't teach the examiner. You do it. Shake the patient's hand, the patient's peripheries are cold and clammy. You'll feel it. And then after that, you look at temperature. When you're saying for temperature is comparative, yeah, you feel across the length of the arm slowly, jumping from here to the next, feeling to the next, feeling. Yeah. What am I saying for? What would it be saying if the temperature is cold? Let's say the patient is non-hypertensive, non-adherent to antihypertensive medication. Why would the patient's peripheries be cold, and why is that important to me?
So that would be a macrovascular complication, so like peripheral artery disease. We're trying to assess for that.
Thank you so much, Ian. Thank you so much. You're very correct. You are saying for PAD, peripheral artery disease. Cold periphery is normally one of the first changes that happens. They become cold before they change color, before an ulcer appears, they are cold first. So that's important. Thank you so much, Ian. So let me ask you guys about the pulse. First of all, which pulses do you know in the body? Maybe I could ask Musoba Edith this question. Or Edith, are you in a position you can talk?
Yes, but not much.
Okay, which pulses are you aware of? Just run me through the pulses you know quickly.
Radial pulse, brachial pulse, those. The one on the dorsum of the feet. I've forgotten the name.
Dorsalis pedis, thank you. Continue.
Yeah, then popliteal.
Yes, yes.
Then I think on the neck, the jugular.
Yeah, carotid. Thank you so much, Edith.
The carotid, yeah.
Thank you so much, Edith. There's one that has been forgotten, that's posterior tibialis. Thank you so much, Edith. So these are the pulses. Please know where they are anatomically. How do you locate them? And these are the sessions we'll do physically. I'll have to show you how to look for dorsalis pedis. I'll have to show you how to look for posterior tibialis and how to look for the popliteal artery, how to accentuate for these arteries. Because you know, this is about semantics. Yeah, medicine is about semantics. It's almost like law. The language is very important. Yeah, but now in the doctors are very dramatic. They have a flair for the dramatics. So when you are doing this exam, you might quickly rush and feel and say, oh, pulse is present and palpable, but you have not really felt for them because you've not accentuated for them to look for their locations. Yeah. Those are the things I remember going through in anatomy. You know the popliteal artery, you know where it is in relation to uh, how it runs, yeah, in the popliteal fossa. You need to know your brachial artery, the anterocubital fossa. Once again, I've taken you a bit into that. The radial artery, how could you make it more accentuated? So those are the important things you have to do. So, any question on the cardiovascular exam or anything we've done till now?
Yeah, I have a question.
Yes.
For when you're talking about the pulse,
Mhm.
and you said there are only three ways you can say it is regularly, regular, irregularly, regular, and irregularly, irregular.
Mhm.
What exactly do you mean by that?
So it's about, in pulse, you're talking about the rhythm, yeah? That was the rhythm. I didn't want to really delve deep into the character, into the volume, into the wall until you are together, yeah? But the most basic thing starts with the rhythm. So the rhythm of a pulse is either regularly, regular. So in short, you're feeling it, it's beating regularly. So it's maintaining a consistent beat. It maintains a similar pattern. There's no drops, there are no peaks. It's just like that. It could be regularly irregular, meaning that it has a pattern, but there's a point it drops. And it drops at a specific point. So you could be counting 1, 2, 3, 4, drop. Then 1, 2, 3, 4, drop. Yeah. And then irregular, there is no pattern. The peaks and the drops, they happen at whatever time. And that's a sign of atrial fibrillation. I hope I've answered your
Got
question.
it. Yeah.
Yeah, but we'll talk about the character, we'll talk about the volume when we are together. This one, I can't do it online. We have to be together. Any other question on anything that I've done so far? But okay, thank you so much, Andrea, for presenting the history today. I saw Daksh raise that he had a history. I would like to listen to that history. Could we schedule a time for maybe when we are together physically? I listen to a couple of more histories because there are some things I also want to correct. You guys, the exam is ever drawing near, and there are a couple of things you must know. You must not go presenting without any direction. Please, guys, know that when you're presenting a history, you're communicating, yeah? You're not presenting a set of points and you're not reading off a teleprompter or a paper. You should maintain eye contact with the examiner. Look the examiner in the eye. Do not waver. It shows that you know your patient. You're familiar with this guy. This is not a guy that you just clapped because you had the aim of talking about a disease. You know the person. You understand him from all in the biopsychosocial model. So you know this guy. So you can't be presenting the patient like points. Yeah. It really irritates anyone who's listening. Like, so the name is, the age is, gender is, continuous prose. That's the first thing you need to work on. I'm being informed tomorrow, read on sickle cell disease. You'll be having a common session with my colleague, Kerario Keith, and he'll be taking you through sickle cell. So read in Davidson's. Don't read. I'm advising you guys, and let me even just stop the recording for this, and I give you these hard truths.